I'm Christina. This is Outcomes, and it is 2025. The worst thing that you can do is craft a healthcare system based on the needs of the average person and not the average patient. This is Outcomes, and I talk about healthcare finance and business strategy through the lens of social impact. And today we're talking about interrupting high utilization patterns. And we'll start by taking a look at what can happen when systems are designed for the average person as opposed to the average patient. So a few months ago, I posted on LinkedIn about how something as simple as a transportation program, something that seems so benign, it's non-medical, it's post-discharge, can get so wrong. So in this program, I kind of talk about in my post how people's cars, their rides get mixed up. They don't get the text confirmations because they don't have phones, or the text goes to the wrong person. They don't get rides to their shelters or their alternate living situations. They don't have an adequate access in underserved areas. They don't have adequate service for people with mobility issues. So again, this is a perfect example of a well-intended transportation program that was designed for the average person and what the average person can do, the assets that an average person has, as opposed to what the average patient looks like and needs in 2025. The top 5% of healthcare users account for a disproportionate amount of healthcare spending and utilization. These high-need patients are responsible for 69% of all home health expenses and 75% of all hospital inpatient expenses. Now, who is the average patient? We're talking about older patients, particularly those 65 and over. They tend to have higher healthcare utilization. There's education and economic status, and these are factors that can influence patient preferences, utilization patterns, though this relationship is complex. There's multimorbidities, the presence of two or more chronic conditions, and it's extremely common, with 75 million of US adults falling into this category. On average, the average patient visits multiple healthcare providers. Only 26% of patients visit a single provider, while the majority see two or more. Then they are primary care. So the highest share of visits is to primary care physicians. So the average patient is seen in a primary care office. Next is most patients are chronic conditions, and this includes mental health, psychiatric diseases, substance abuse. These are significant factors in the average patient's complexity. Then there's infection risk, and the risk of acquiring a hospital-acquired infection is a top concern for the average patient because they're the highest utilizers. Let's look at 3 proven approaches to breaking utilization cycles. So you take a look at Highmark's True Performance program that focused on actual high-need patients and saved $4 billion by the end of 2024 by getting 13,000 physicians to focus on prevention and coordination for their most complex patients. And the results were $766 million saved on inpatient admissions in 2023 alone. Another example is in 2019, Kaiser Permanente's Housing First initiative demonstrated improved health outcomes early on in physical and mental health, and in fact reduced ER utilization by 37% and led to a 27% reduction in overall health costs. And what is meant by housing first is the approach of providing housing along with comprehensive holistic services, including healthcare, social care, care coordination, as opposed to the standard approach to traditional housing programs that were always treatment first, requiring patients to be in psychiatric treatment and substance abuse free in order to be housing ready. So the support provided stayed the same, but the ordering of how those services and resources were accessed was shifted to be more in line with the population's characteristics, needs, behaviors. So again, it's a perfect example of the success in designing for your actual users. Then there's trauma-informed programs, another example of breaking the cycle in this case in mental health crises. So these initiatives have shown a lot of success in reducing crisis visits and importantly reducing seclusion and restraints. And this is about understanding what the trauma response is. And so the common thread of all these success stories is that they all required us to challenge our assumptions about how care should be delivered. And each one represents a shift away from this is how we always done it to this is what actually works. As I wrap up, I have a question for you. Look at your last major system redesign or process improvement initiative. Was it designed for the average person, someone who's generally healthy, resourced, and accessing preventive care? Or was it designed for your average patient, someone managing multiple chronic conditions, juggling various providers, and navigating complex social needs? Take a moment to audit your current initiatives. How many of them would work for a patient without a phone, without reliable transportation, without stable housing? These answers might surprise you, and they might just reveal your biggest opportunity for value-based care, success, and more.